Hello everyone. So moving forward with the upper limb anatomy. So we're going to talk about the upper limb muscles, and we're going to start by the rotator cuff muscles. So the question is asked about the attachment, which include the origin and the insertion, and also the nerve supply of these muscles. With regard to the action, it has different questions that we're going to talk about the abduction of the arm from 0 degrees up to more than 120 degrees. All right. So we're going to come to this later on. So starting by looking at this dissection, so you have a muscle. So obviously this is the spine of the scapula, muscle just above the spine, which is coming from the supraspinous fossa. So that will be the origin of the supraspinatus muscle, and the insertion will go to the greater tuberosity of the humerus. And on the other side, so obviously the greater tuberosity the muscle will go from here all the way to there. But obviously the deltoid muscle is covering that. The next dissection will show you where exactly it inserts. The infraspinatus muscle, it takes from the infraspinous fossa. And the teres minor muscle, as you see here, this is the lateral border of the scapula. So it takes from the upper two-third of the lateral border of the scapula and then inserts into the uh, the greater tuberosity as well. So these are the set muscles, and they all insert into the greater tuberosity. Okay, so look at that. So this one is even better because we've removed the deltoid muscle from that. So this is the spine of the scapula, and you have here this is the supraspinatus, and then says in the greater tuberosity, and this is the infraspinatus muscle. All of this is the infraspinatus, and the insertion again greater tuberosity, and this is the teres minor from the upper two-third of the lateral border of the scapula, and insert into the greater tuberosity. This is the teres major muscle, and it basically inserts into the medial lip of the bicipital groove. But it's not one of the rotator cuff muscles. So medial lip of bicipital groove. Okay, but we're coming to this later on. Bicipital groove. You have here in terms of the nerve supply, you have from there is a nerve called the suprascapular nerve. So it does give supply to both the supraspinatus and the infraspinatus. And for the teres minor muscle, you have the axillary nerve will be coming from here. So it will give supply to the teres minor muscle. So axillary nerve for teres minor muscle and the suprascapular nerve for the other muscle, two muscles, which was supraspinatus and infraspinatus. On this one, so we're looking from the front, and this is the scapula over there, and you have this one is the subscapularis muscle, so taken from all the subscapular fossa, and it's going again to the greater tuberosity of the humerus, and the nerve supply is the upper and lower subscapular nerve, the upper and lower subscapular nerve, and this is from the brachial plexus. So very quickly, just to revive the text in here. So supraspinatus, supraspinous fossa, greater tuberosity, suprascapular nerve, infraspinatus, infraspinous fossa, greater tuberosity, suprascapular nerve, and teres minor, upper two-third of lateral border of the scapula, greater tuberosity, axillary nerve, and this one is the lesser tuberosity, upper and lower subscapular nerve. Moving forward, the clinical significance of the rotator cuff muscles, we mentioned that the shoulder joint early is an unstable joint due to very shallow glenoid cavity and the absence or basically very lax joint as well. So it's one of those things that stabilize this joint in the rotator cuff muscles. The attachment to the tubercles, so obviously it does attach to the greater tubercle and lesser tubercle as well, and nearly complete musculocutaneous ring over the joint or the shoulder joint would serve as the main source of the stability for the joint. So looking at this diagram or illustration, you do have here, this is the glenoid cavity, and around the glenoid cavity, you have the glenoid labrum, which is this one. So this is the glenoid labrum, which gives the glenoid cavity some sort of more cavitation to make the joint a little bit more stable. In terms of the muscle, on this side, this is the side of the greater tuberosity, and on this side, this is the side for lesser tuberosity. So this muscle in here is the subscapularis muscle, and this muscle is supraspinatus, and this one is the infraspinatus, and also the teres minor muscle as well, right there. And as we explained earlier, it will make like a complete muscular ring or musculotendinous ring around the glenoid cavity to form the main source of stability for the joint. So this is subscapularis, and this is teres minor, and infraspinatus, and that's the articular surface. All right. So these are the main function of the rotator cuff muscles. The shoulder joint abduction muscles involved, we mentioned that supraspinatus will give from 0 to 15 degrees, and the deltoid muscle from 15 to 90 degrees, and above 90 degrees will be serratus anterior and trapezius muscle. Moving on, the biceps muscle. The biceps, from the name, it does have two heads, and the two heads of the biceps, basically, you have the long head, which takes from the supraglenoid tubercle, and the short head will take from the coracoid process. They will join together, just like that, to form the biceps muscle, and they will insert through the biceps tendon down in the radial tuberosity. We explained this on the osteology part. And the nerve, it takes from the musculocutaneous nerve, which we're going to show you to in a second, and the relation related to the median nerve and the radial nerve as well. One is medial and the other one is lateral. But look in here to confirm this. So this is the biceps muscle. I can't really show you because the deltoid is covered, but they have the long head from the supraglenoid tubercle, short head from the coracoid process, and they all go down to be inserted into the radial tuberosity, which will be sort of in this area. As you see here, the muscle will be sort of in this position. It will be related to the median nerve, which you can see this is the median nerve down there. We'll see that is an artery. Well, this way, going down, this is an artery. So you have the median nerve and also the radial nerve, which will be on this on the other side as well. This is the radial nerve. So radial nerve is lateral and median nerve is medial side. Actually, this is the musculocutaneous nerve which supplies it. All right. So these are the biceps brachii muscle, and in this diagram you can use it as well for the muscles on the front of the arm. So like biceps brachii and the coracobrachialis muscle, brachialis muscle as well. Or you can use it at the flexors of the elbow. Those three muscles are the flexors of the elbow. Moving forward, you have the triceps muscle. It has three heads, and you have the long head and the short head. The short heads will be the triceps brachii, the lateral head, and the triceps brachii medial head. So look in here, this is the long head, and it's coming from the infraglenoid tubercle, and then the lateral head will be, and the medial head. So the medial head will be on the just below. So the medial head just below the spiral groove, and the lateral head will be above the spiral groove. All right. So yeah, these are the origin, and the nerve supply will be the radial nerve, and the insertion will be in the olecranon on the back of the ulna. All right. So the origin, we talked the long head infraglenoid tubercle, and lateral head above its spiral groove, and medial head below spiral groove, and then radial nerve as the nerve supply. The forearm muscles, there are many muscles in the forearm, and we can classify it into the superficial group, and then the intermediate group, and then the deep group of the muscles. As you look here, these are the muscles of the superficial group, and you have obviously the biceps brachii is not one of these muscles because it's one of the arm muscles. They all tend to have an origin from a common flexor origin, which is the front of the medial epicondyle, and you will have the pronator teres, this one of the superficial, and then the flexor carpi radialis, which is this one, the flexor carpi ulnaris, this one, and also the palmaris longus. Sorry, this is palmaris longus, and then flexor carpi ulnaris muscle. So these are the muscles for the superficial. The intermediate group will be the flexor digitorum, and then we're coming to the deep group. So I'm just going to mention a few things on that. So the notable attachment, you know that all of them will come from the common flexor tendon, which is in front of the medial epicondyle. All of them as action. So in terms of flexor carpi radialis, that will cause and both of them, carpi radialis and carpi ulnaris, These are the primary flexors of the radiocarpal joint or the rest joint, right? These are the flexors of the rest joint. Carpi radialis can also abduct or radial deviation of the rest joint, and FCU or the carpi ulnaris would be adduct or ulnar deviation. And the pronator teres, which will pronate the radio-ulnar joint, will cause some sort of pronation in the arm. All of them are innervated by the median nerve, except the flexor carpi ulnaris, which is supplied by the ulnar nerve mainly. All right. So these are just like quick notes on the flexors of the forearm. In terms of the intermediate compartment, you have the flexor digitorum superficialis muscle, and we sort of can see it here. This is the flexor digitorum superficialis, and the attachment, um, the proximal attachment of this muscle is coming from, again, the medial epicondyle, which is the common flexor origin, and the insertion. The four long tendons will traverse the carpal tunnel, and then they're attached into the intermediate phalanges, right? But remember that on the insertion, the tendon will divide into two pieces, just like that, and that will be the digitorum superficialis, and the profundus will come in between to insert in the DIP, or the distal interphalangeal joint. So they all flex. So this muscle will flex the rest joint and the metacarpophalangeal joint, and also the proximal interphalangeal joint as well. And the deep layer, it will contain the flexor digitorum profundus and the flexor pollicis longus, and also the pronator quadratus. Again, digitorum profundus will come from the common flexor origin, which is the medial epicondyle, and the flexor pollicis longus tendon traverse the carpal tunnel distally and attach to the distal phalanx of the thumb from obviously the palmar surface. And the action for the digitorum profundus, it will flex all the joint that it made. So in terms of the carpometacarpal joint, and also metacarpophalangeal joint, and the proximal interphalangeal joint, and also the distal interphalangeal joint as well. The pronator quadratus will obviously, from the name, will cause pronation, and the ulnar deviation will be by the flexor digitorum profundus. The unique innervation will be from mainly from two nerves. So we'll take from the ulnar nerve and the radial nerve. So at this point, we can say that all the flexors will be supplied by the median nerve, except for the flexor carpi ulnaris and the medial half of the flexor digitorum profundus muscle. All right. Yeah, we talked about muscles flexing the elbow, and it's these muscles we mentioned before, and they are all supplied by the musculocutaneous nerve. Finally, in terms of flexor digitorum superficialis and profundus, and how do they insert and how can you test them? So we mentioned the digitorum superficialis, the tendon will split and will insert into the proximal, actually the intermediate phalanx or the middle phalanx, and then the profundus will insert into the distal phalanx by passing between the splitted tendon. So that will tell you by the action of the digitorum profundus, you need to exclude the surrounding fingers by keeping them extended and just move one finger to test the distal interphalangeal joint. You can also fix the proximal interphalangeal joint and ask the patient to fix. So for flexor digitorum superficialis, just fix the surrounding fingers, and digitorum profundus, just fix the proximal interphalangeal joint. So we mentioned this earlier as well, which tendon is attached to the pesiform. It will be the flexor carpi ulnaris, and we mentioned that earlier today as well. Right. So in this one, this is a quite tricky diagram, and I believe we haven't came through it before. So these will be the extensors of the fingers and the extensors of the rest as well. So looking at this one, let's start from the distal. So you have on like sort of four tendons. Number one, that will be the flexor digitorum, the extensor digitorum, and then two, that will be the extensor endesis, and you have this muscle will be the first dorsal interosseous muscle, And this is something called the intertendinous connection between all the extensors. And you have this area, this is the radial styloid, that's radial styloid, and this is the ulnar styloid. And yeah, so these are the main muscles. Number 8, this is a muscle that is going to the smallest finger, so that will be the extensor, the abductor digiti minimi, the abductor digiti minimi. Two muscles that can be easily confused. It's a 10. So 10, you are on the thumb side or on the radial side, so that would be extensor carpi radialis brevis, extensor carpi radialis brevis, because you are on the radial side. But there is another muscle which would be extensor carpi radialis longus. I'm just trying to find it. Seven is obviously extensor carpi ulnaris because you're on the ulnar side. Extensor carpi radialis longus will be 9. Yeah, this one. This one is the extensor carpi radialis longus, and this one is extensor carpi radialis brevis. All right. So these are the extensors of the joint. The intertendinous connection, these connections sort of create some space between the extensors, and it coordinate the extension and stabilize the joint, the metacarpophalangeal joint, and also redistribute the force. You can see here, this is the palmar aponeurosis, and this is where Dupuytren's contracture can happen. And this is the palmar carpal ligament as well. And there is a tendon in there. This is the palmaris longus. What we're trying to see here, that palmaris longus is the only tendon that is superficial to the palmar carpal ligament. All right. Looking at this one, it's a little bit deeper. So here, this is the ulnar nerve. You're in the medial side. So this is the ulnar nerve. And this is the median nerve because you are on the lateral side. And this is the transverse carpal ligament. And this is the ulnar nerve, all right? So these are all the flexors. Obviously, that would be the radial artery as well. Nerves of the lower limb, we're going to start by the brachial plexus. And the question is asking about the surface anatomy and the parts location of the brachial plexus. So looking at this dissection you have here, this is the origin of the brachial plexus, which comes from C5 and C6 and 7, 8 and T1 as well. So these are the origin of the brachial plexus, and usually these are the roots, and the roots will start binding together to form the trunks. So this will be the upper trunk of the brachial plexus, that will be the middle trunk, and that will be the lower trunk of the brachial plexus. And then each trunk will divide into divisions. So that's a division, and that's another division. Here, that's a division, and that's another division, and from there, that's a division, and that's another division as well. And then all the posterior divisions will combine together to form the posterior cord of the brachial plexus, which is, this is the posterior cord, and that's the one that will give the axillary artery. As you see here, this is the axillary artery, and also the radial artery as well. And you have the medial cord, which is, this is the medial cord, and also the lateral cord on the other side. And the lateral cord will give the musculocutaneous nerve and will give part of the median nerve. So when you look here, that will be the median nerve, and this is another division in there that will join as part of the median nerve. So all the posterior cords will give the radial nerve, and this is the median nerve, and you have the axillary and the musculocutaneous nerve as well. So the question is asking about the surface anatomy. So usually the surface anatomy is it's 2 inch from the sternoclavicular joint between the scalenus anterior and the scalenus medius, and that's in the root of the neck. So you get here the sternoclavicular joint will be sort of here. It's 2 inch, so that will be where is it on a living subject. And also in terms of the roots, so the roots of the brachial plexus will be between the scalenus anterior and the scalenus medius. And as you can see here, this is the scalenus anterior. The scalenus medius will be the one behind in there. So that's the scalenus anterior, and this is the scalenus medius, and all the roots is coming between those two muscles. And then after the roots, you have the trunks, which we mentioned, upper, middle, and lower trunk, and that will be into the base of the posterior triangle, just behind the third part of the subclavian artery, and this is obviously the subclavian artery in there, so that would be just posterior to it. And the divisions, which we mentioned, these are the divisions are highlighted for you. So that's a division in there. That's another one, and these are the posterior divisions, which will give the posterior cord that will terminally give this nerve, which is the radial nerve, and this is the axillary nerve, and yeah. So this is the cord, the posterior cord of the brachial plexus, which coming from these sort of greenish divisions. That's the other division in there, which will give the medial cord, which is this one, that will end up by giving the ulnar nerve, all right, which it will be the big one in there. This is the ulnar nerve. All right. So the divisions usually into the middle third, just behind the middle third of the clavicle, and also the cords, which these are the cords. So you have the lateral cord, which is this one, and then the posterior cord, like we mentioned, and also this is the medial cord as well. And the cords are usually related to the second part of axillary artery. So as we said, so you have the roots. These are the roots of the brachial plexus, and after the roots you will have the trunks. So these are, I mean, it's sort of like that. So these are the trunks. Yeah, so these are the trunks of the brachial plexus, and the trunks related to the subclavian artery, the third part of subclavian artery. And then you have the divisions, and the division will be behind the middle third of the clavicle. These are the divisions. And then finally, you have the cords, and that will be related to the axillary artery, the second part of the axillary artery. Well, so these are very quickly the brachial plexus, and then we're going to talk about two quite related injuries to the brachial plexus, and you have the Erb's palsy and the clumps paralysis. So in terms of Erb's palsy, that's from the top, so C5 and C6, and this happens when you sort of start pulling the arm all the way down, all the way down, so that will sort of cause some tension on the roots and will lead to paralysis of C5 and C6 as well. And this happens usually during delivery or during delivering the child with shoulder dystocia. And the key word in here, so obviously when we're talking about nerve injury, we need to establish the motor affection, the motor effect, and also the sensory effect as well. So in terms of the motor with Erb's palsy or Erb's paralysis, you need to remember the waiter's tip. When you look here, this is the waiter's tip, all right? So and then start to describe it from the top to bottom. So initially, the arm will be adducted. Okay, the arm will be adducted due to paralysis of the abductors, and that will be the supraspinatus and also the deltoid muscle as well. And also the elbow will be in extension. So to the elbow will be in extension, and due to paralysis of the flexors of the arm, the forearm, and the forearm will be supinated. Sorry, the forearm will be pronated due to paralysis of. Sorry, the forearm will be. So let me double check that. And the forearm will be pronated, and also the rest will be flexed. That is the with sort of ulnar deviation, with sort of ulnar deviation. So if we go back, yeah, so these are the effect on the upper limb. There'll be arm adduction due to paralysis of the abductors of the arm, and that's supraspinatus and deltoid muscle, internal rotation, paralysis of infraspinatus anterior minor muscle, and elbow extension and forearm pronation, and then rest deflection with rest ulnar deviation. And sensory will be basically on the radial side, as if the median nerve is affected. Okay, so these are the paralysis of C5 and 6, or injury in C5 and 6, which will happen with shoulder dystocia, and can also happen with a condition that is called the Pancoast tumor, or any tumor that causes compression on the proximal part of the origin or the roots of the brachial plexus. Clumps paralysis that would be injury to the lower end, so C8 and T1, and that will happen when you start pulling the arm on the other way around. So let's say your arm is hanging in a tree, and that will cause sort of tension on C8 and T1, and will lead to paralysis to that. And that the key word here, like we mentioned in the Erb's palsy, will be claw hand, and this is a complete claw hand deformity. And the definition of claw hand is basically hyperextension of the metacarpophalangeal joint and the flexion of the interphalangeal joint. And then you're going to mention which muscles are affected. And then you have paralysis of all the wrist and fingers flexors, and paralysis of all intrinsic muscles of the hand, and also loss of sensation on the ulnar side of the forearm as well. So this is the criteria, this from Kenhub, and this is the criteria of the complete claw hand. That's hyperextension of the metacarpophalangeal joint and flexion of the interphalangeal joint. Basically, hyperextension due to paralysis of all the flexors of the metacarpophalangeal joint and flexion due to paralysis of the extensors of the interphalangeal joint as well. And sensation will be on the radial side or toward the thumb. Yeah, so that was the brachial plexus, and we talked about the cord, the roots, the cords, the divisions, and finally the cords. And after that, we talked about the Erb's paralysis and the clown's paralysis. The key words is waiter's tip, and also the keyword is complete claw hand. Well, axillary nerve, motor and sensory distribution. So very quickly, we talked about the axillary nerve origin. That would have been from the posterior cord. So if you look here, so this is the posterior cord, and it will give a nerve that will come like that and moves laterally and enter into the quadrangular space, and it rotates around the humerus and give nerve supply to two muscles. We mentioned the deltoid before. That would be one of the muscles, and also one of the sets muscle. We mentioned supraspinatus is suprascapular, infraspinatus is suprascapular nerve, and the teres minor will be the axillary nerve. So the motor supply by the axillary nerve will be the deltoid and teres minor muscle, and the sensory supply is skin over the lower half of the deltoid or the badge area. And any injury to that will lead to paralysis of the deltoid, and that will lead to flat shoulder. The deltoid, if you remember, was responsible for abduction of the this joint, the shoulder joint, from 15 degrees up to 90 degrees. So basically, your arm will not be able to extend beyond 15 degrees, and loss of sensation on the badge area as well. Median nerve, sensory and motor distribution. Remember, we talked about the median nerve origin. It was coming from the union by the divisions to form which cord. So we talked about the lateral cord, the posterior cord, and the medial cord. So basically, all the division will unit to form the median nerve by multiple divisions from these cords. So basically, the sensory will be the lateral 3.5 fingers, and also the palmar surface of the lateral 3.5 fingers, and palmar surface of the lateral 2/3 of the hand. And the muscles, we talked that the flexors of the forearm are all supplied by the median nerve, except for two muscles, which are flexor carpi and the medial half of the flexor digitorum profundus. So basically, all the flexors, remember, we classified them into superficial group and intermediate group and also deep group, except those two will be supplied by the median nerve. It also supplies the thinner muscles, which are basically at the base of the thumb, and finally the loaf muscles, and these are the lateral two lumbricals, opponens pollicis, and epiductor pollicis brevis, and the flexor pollicis brevis. So yeah, looking at this one again, so you have the median nerve, which is this nerve, all right? It's the median nerve, which is this nerve. So back just to track the brachial plexus, you have here, these are the roots, and after the roots, it will give you the trunks, and these are the trunks, and then you have multiple divisions, and then the cords. And then the cords, you have part of the cords in there, which is the lateral cord and medial cord will participate into formation of the median nerve. and it will descend all the way down. It passes through the cubital fossa, which we remember relation to the biceps muscle, was it's medial to the biceps muscle, and the radial nerve was lateral to the biceps muscle. So it will be medial to the biceps muscle, and it will give nerve supply to all the muscles of the forearm, or the plexus of the forearm, except flexor carpi ulnaris, and also the medial part or the ulnar part of flexor digitorum profundus, and the thenar muscles and the loaf muscles as well. On the other side, you have ulnar nerve, motor and sensory distribution. So it will be the rest of the palmar surface of the hand, which is the medial third of the palmar surface of the hand, and also the medial 1.5 fingers as well. All right. And the muscles were mentioned in the forearm. It will give the flexor carpi ulnaris and also part of the flexor digitorum profundus, and it will give all the intrinsic muscles of the hand. It will give the medial two lumbricals, and we know that the lateral two lumbricals part of the medial nerve, and all the interossei muscle, and the adductor pollicis, and the D part of the flexor pollicis brevis. So on this side, you can see that the medial nerve. So again, these are the roots, and then you have the trunks, and then you have the divisions, and then you have the cords. So this is the lateral cord, and this is the medial cord. This is the median nerve here. That's the median nerve, and that is the ulnar nerve going all the way down, and it will be just behind the medial epicondyle. And on this one as well, distally, so this is the thumb, that means this is lateral and this is medial. That's the median nerve on this side, and as you see, it's going all the way up to the thumb. So that's mainly, will tell you that it will give sensation sort of on basically all this area will be the sensations of the ulnar nerve, and it will give all the muscles, all the interossei, the medial two lumbricals, the hypothenar eminence, and then the other side, that will be the median nerve, will give all this area in terms of sensation and in terms of the loaf muscles, and also the lateral two lumbrical muscles as well. Well, next is the radial nerve, and if you look here, so again, this is the posterior cord. You have here, this is the radial nerve, and it will go into the spiral groove and the back of the humerus, and then will go all the way down to give all the extensors of the elbow, and it will give just sensation in the first rib space, basically where the anatomical snuff box is, and we're coming to talk about the anatomical snuff box as well. All right. So this is a diagram just to summarize the sensations. So you have, in terms of sensation, this is the radial nerve, and also from the back as well. And this is the median nerve area, and also these are the median nerve again. And it's basically the cutaneous branch of the median nerve, and that is the ulnar nerve. Okay. So the radial nerve, we mentioned that it supplies all the extensors, and it plays an important role in making a power grip. And the radial nerve supplies the extensors, and this gives mechanical advantage to the power grip and synergetic effect or synergetic activity, which leads to the flexion to be more efficient or more effective. Again, this is a very similar one. So we'll see that is the thumb, so that is lateral, and that is the little finger, so that is medial. You have here, this is the median nerve, will be number 16, and 25 is the ulnar nerve. And again, sensations will be sort of here for the ulnar and here for the median nerve. Okay, so talking about some injuries, we're going to talk about radial nerve injury and the median nerve injury and ulnar nerve injury as well. So starting by radial nerve at the spiral groove. So we mentioned that for everyone, you're going to cover sensory sensory effect and also motor effect. So in terms of motor, it supplies all the extensors of the elbow and also all the extensors of the wrist and the fingers as well. So it will lead to something called wrist drop and finger drop due to paralysis of all the extensors. And sensation, we explained it early, so loss of sensation in the first rib space as well, on the dorsal surface. Median nerve injury, so the injury of the median nerve can happen at the elbow joint and can happen at the hand joint. By definition, if it happened at the elbow, it will affect from the elbow all the way down, including the hand and the elbow as well. But for just convenience, we're going to divide it into elbow and hand. So Sensation, we know the sensation for the median nerve is the palmar surface of lateral 2/3 of the hand and the palmar surface of lateral 3.5 fingers. That will be completely lost if it's affected. In terms of motor, we talked about the muscles, which are the flexors of the arm, the flexors of the wrist joint. So basically, all the flexors will be affected. So obviously, the arm will be in supination due to paralysis of the pronator and weak wrist flexion, because we only have two muscles that will work on the wrist flexion out of around like 8 to 10 muscles. So apart from the flexor carpi analysis, all the other muscles will be affected. Because the flexor carpi analysis is still working, there will be sort of ulnar deviation, and there is something called sign of benediction. When you ask your patient to try to make a fist, so if you ask your patient to make a fist, only those two fingers will be able to flex, but the lateral 3.5 fingers unable to flex at all. And also the thenar eminence will be very flat, and basically muscles are lost. So this is called the sign of benediction, all right? Sign of benediction, or the Pope's blessing. So if you look at that, so sign of benediction due to loss of flexion of the index and the middle finger as well. Here will always be extended like that. And ape-like hand, the thumb will be sort of adducted because the adductor pollicis is supplied by the ulnar nerve, and the opposition at the opponent's ball, remember the loaf muscles, will be affected as well. So to summarize this, always remember the muscles. So we talked that the ulnar nerve supplies all the flexors, and these flexors will be affected, apart from flexor carpi ulnaris and part of the flexor digitorum profundus. So that means that if the wrist flexion is lost, there will be sort of ulnar deviation because flexor carpi ulnaris is working, and also there will be sign of benediction as well because the we'll see flexor digitorum superficialis and profundus are not working. So the flexion of the index and middle finger will not be working. On the thumb, the opponent's pollicis will not be working. The thumb will be adducted because adductor pollicis is still working, and obviously the loss of pincer grip, and the patient will have difficult in doing buttoning on the shirt and so on. And we mentioned the sensory as well. So if it's affected at the hand, that means we have a spared which muscles, all the flexors from the top. So the flexor digitorum and so on will be working, okay, because obviously the injury is just beyond these muscles. So, but you will still have flattening of the thenar eminence and adduction of the thumb and loss of opposition and loss of pincer grip, and that's the injury at the hand. That's why we tend to classify it into hand and elbow joint. Well, the ulnar nerve injury, clinical picture. So again, you always start by sensory and motor. So sensory, the sensation on the palmar surface of medial 1/3 and the medial 1.5 fingers will be lost. And motor, remember the ulnar nerve supplies two muscles in the forearm, and this is flexor carpi ulnaris. That will be lost. So again, you will have a little bit weak wrist flexion and sort of radial deviation. And you will have something called partial claw hand, and that means hyperextension of metacarbophalangeal joint and flexion of interphalangeal joint of the medial two fingers, all right? Of the medial two fingers. So hyperextension and deflection, and this is due to paralysis of the lumbricals and all the interosseians. Yeah, so this is claw hand, if you look here, and this is sign of benediction. So benediction means flexion here is working, but flexion here is not working. But claw hand is hyperextension and also flexion of the interphalangeal joint. And this is from Dr. Nabil Ibrahim from YouTube. The ulnar paradox is basically the clawing would be a little bit more of if the injury of the ulnar nerve is at the wrist rather than at the elbow. And the main reason why due to the balance between the flexors and extensors. So when you have the injury at the elbow joint, the flexor carpi ulnaris and the flexor digitorum profundus will not be working. They will not participate in flexion in the metacarbophalangeal joint. So the clawing will be a little bit less than the injury at the wrist joint. Because when you have the injury at the wrist joint, the flexion of metacarpophalangeal joint will be working by the flexor carpi and flexor digitorum profundus as well. That's why it's called a paradox. You would expect if the injury is higher, the symptoms will be worse, but here, the higher the injury, the less the effect. Why hand grip is powerful in extension rather than flexion? Because the flexor muscles in extension are in a position of tension, and that will lead to then in flexion position. So contraction is more powerful when your hand is a little bit in some extension. All right. So thank you. That covers the nerves as well, and we're going to finish by the spaces and the blood vessels in the next video. Thank you.